Yeah, so, let's restart the program. Our next speaker is Dr. Avina, and Dr. Avina is the BC Lupus scholar. We happily support him and his research, and actually a big part of his role is to train the next generation, so that's a big purpose as well. So, yeah, with no further ado, Dr. Avina.
Thank you. Just for those, I'm happy to see new faces, actually. As Jen has mentioned, we always have done this for quite a while. But I see a lot of new faces. This is good, I think. It's good to get new people engaged. And by the way, who is a mother here? Okay, today I'm a Mexican by birth. And today is Mother's Day at home. So happy Mother's Day. It's always on 10. Like in Canada, unlike Canada, which is always on the second Sunday of May, in Mexico, so happy birthday, happy Mother's Day. And the collaboration with the BC Lupus Society has been always for 15 years since I came to do a PhD, and this is you guys through your fundraising put food on my table. It has been continued support for 15 years. I always believe that the best investment is always in people. And every time I go and present in my research, I always put the BC Lupus Society. They ask me, are they paying you? Yeah, they've been doing it for 15 years. And this is something that very few organizations do. And I think it's very important to keep doing it, not just because I have food on my table, because it creates an opportunity to recruit people and stay here. A little story, I actually didn't want to be a rheumatologist. I wanted to be a surgeon. And then I encountered a lupus patient. And I saw that it was, if you treat and diagnose appropriately, you change the life. So I think maybe this is something that I actually could do for a living. And I was afraid of developing arthritis in my hands and then not being able to use as a surgeon. So I said, if I can still use my brand, then I'll be probably safer. So that's why I switched to be a rheumatologist and a lupologist. So thank you for what you've been doing, and I hope it continues. And I'm happy to see that the BC Lupus Society is coming back again alive. It was a little bit quiet for a while, and I know how difficult it is to find volunteers and a leadership. But I'm happy that Ivana is actually taking over. So thank you. So without more stories, I have to say that I was recruited to do research and in lupus, and I do research and other things, but lupus is close to my heart. So I'm going to give you an overview of the current research that we're doing, and some you may actually have heard through your rheumatologist or our website in Arthritis Research Canada, or through calls through my research team. So one is the INTACT study, as we already know, Jen mentioned. Hydroxychloroquine is a cornerstone medication that all patients with lupus should be taking. Actually, the next lupus conference that's happening in 2 weeks is going to be in Toronto for lupus, is the World Congress of Lupus. And I'm actually chairing a session about antimalarials. Hydroxychloroquine is one of them. And we're going to make a big discussion on breaking myths. And then now is in the discussion, do we really need to have everybody on hydroxychloroquine? Given the new therapies that we're having now, if cost was not an issue, maybe we should be using other therapies in non-hydroxychloroquine. This is going to be quite an interesting and fun topic. But anyway, at the end of the hydroxychloroquine should be taken by everybody. It's one of the oldest drugs, but it has a bigger concern of developing eye toxicity, which if we don't explain to the patients when we prescribe them, then they get scared. Now, a lot of people don't take it because, I mean, you could lose your eye or your sight, and that's a very scary thing. But that was in the old days. Now, when we diagnose that complication, is too late, or was too late. But now there's new technology called OCT, which takes a very nice picture of your retina and identifies early diagnosis. And that came out actually a few years ago, that the frequency of retinal toxicity was higher than we thought. I probably found in the world no more than 500 cases of actual toxicity in the entire world ever reported. I know there are more cases that have never been reported, but it's actually a very rare side effect. But with the new technology, it's showing out that it's earlier, and it's probably you stop the medication, you probably will not progress to what we call bull eyes, which is irreversible. So since nobody knows exactly the rate or how frequent it is, we decided to do, we got almost $100,000 from the feds to do a study, including everybody in BC who has been on the medication for more than 5 years. And then we follow them for 5 years, and we create a network of retina specialists. The diagnosis has to come really from a retina specialist, not the general ophthalmologist or not the general optometrist. And sometimes when we get people who have been told that they have retinal toxicity, I always send them back to a retina specialist, and 9 out of 10 or 10 out of 10 is actually no retinal toxicity. But still, it's important to know what is the actual risk, and this is one of the objectives of the study. And those who develop, what are the risk factors, and also once you have it, what happened. There's very few follow-up studies on current retinal toxicity. All the ones that were old actually show that once you had it, it never regresses, and then you actually become blind. But I think now is not the case because we detected early with this new technology. So this is one of the studies. As I said, you probably have discussed with your family, with your rheumatologist. If you're not, please, if you have been on more than 5 years on this medication, tell them. They already know that there's a study called the INTACT study. And we love, you probably saw we love acronyms, and that looks easy to remember, not like the medications we had, the Lumimab, and all that's harder. So INTACT study, everybody knows that. So if you are on this, please make sure you get referral. There's a referral form, there's a protocol. I think it's a very important study, and it's prospectively. Most of the studies that have been done actually were prospectively. So, it's funded, so. I'm not gonna go through this. I'm just gonna encourage you to talk to your rheumatologist to get a referral, and they help her about this. But we are very busy, quite often they forget. So if you are one of those, please remind them. And also, you may not need to see a lot of patients, this is one of the difficulties that we found in our research team. Patients often don't want to go to a different eye specialist because the one that you have is closer to you. But this is the best of the care that you will receive with the retina specialist. So it's only once a year, so I think it's worth it. And I always encourage people, you got benefits for other people that participate in research. Please do your part for the next generation of patients to give a safer medications. So this is another study that we are doing. Actually, we finished and we are just publishing. And we knew that after COVID, some new things will happen. And this is was presented at the European Congress last year. And the retrovirus, the COVID virus is a retrovirus, and retrovirus had been associated as triggers of autoimmune diseases. And guess what? We actually found that people in BC, we examined all people who got COVID and during the crisis, and we followed them a year after, and we found that they have an increased risk of developing systemic autoimmune rheumatic disorders, which is lupus included in that. We analyzed by group rather than single disease because it's a rare disease. Lupus is a rare disease, and that actually increased the risk. And we used a very strict case definition that only lupus-related diseases were increased. So we're gonna see probably more cases of lupus as a consequence of COVID. And this is about to be published, or submitted for publication. So, and we did all the other things in COVID. We saw that people with lupus have a high risk of having severe disease of COVID. We saw that the rituximab, mycophenolate with drugs that actually associated with worse outcome. So we were on top of COVID when the pandemic started. So, and we actually guided the government. And again, as I said before, like Michelle, we tried to influence policy. The government actually recommend lupus patients to get vaccinated faster as a first priority when they saw our data. So we were able to influence policy at the time. So, and now this is a slide this is nicer than the one that Jenny presented. It's a class, I have to say, she always brings the previous slides, but I think I don't have this one. And this is actually from the drug company, as Jen said, they always have more money. And this is a drug that is coming it's another B cell depletion molecule. And remember, in a very simple way, you maybe look normal, but your cells are crazy. Okay, so, and those crazy cells need to be slapped to reorganize through different mechanisms, medications, specific therapies like these monoclonal antibodies or CAR T cell therapy to retrain them. And this is, the B cells in lupus are very important because they're the ones who present antibodies, develop antibodies, and those antibodies are bad. They deposit in kidney, lung, brain, and provoke inflammation. If you stop the cells that produce antibody or interact with other cells to provoke inflammation, this molecule blocks BAFF-R as a receptor. And when you block that, then the cell doesn't have action. You just tie it up and it doesn't go. And other mechanism of action of this medication, the crazy cells actually die. And that's why I think it's important. Unlike belimumab or rituximab, they only control the cells in the blood, but not the ones in the tissue. And I think this is why this medication is going to become probably the best monoclonal antibody that is going to be available for lupus patients, because it also affects the cells that are in the tissue. And I have some data that they did. This is how they presented. Don't worry about it. You just need to know that the response, remember the responses that she was telling you, 30%, 40%. Look at this. This is almost 80% response, which is great. The blue line is the response of patients. And also when you we switch them, the placebo people after 28 weeks, they were switched. They were actually given the medication, and they also respond later at 52, they become still responsive. So this is a very powerful monoclonal antibody that is coming, and we actually doing clinical trial in BC just in the lupus clinic, and we already have, I think, 4 patients for general lupus, but it's also used for nephritis, and we also have, I think, 3 and 2 more screening pending to be approved for treatment. And this is some of the biomarkers. Jen mentioned that the complement is used when the immune system is active. You want to have normal levels of complement. We measure C3 and C4, which are the ones that correlate, and you can see the blue line again. They become very highly responsive. The anti-DNA antibodies, which are bad antibodies, not everybody, but those who have you wanted disappear, and they also show. So we see the clinical response and the clinical response on biomarkers. So, and thank God that we are currently doing this. There's a Lucy network, which is a network of clinical trials, a network from US and Canada to facilitate just clinical trials in lupus. That network has become very important, and I think this is the reason why now we have more molecules to be tested in lupus. It's very difficult to do clinical trials in rare diseases, but that network facilitates the development of new, and now drug companies are actually very actively looking for new therapies. It's a very good time to have lupus now. I mean, it's better not to have it, but 50 years ago, 30 years ago, a decade ago, there were not really new molecules available, but now it is a lot of investment in developing new therapies. So stay tuned. I think the spectrum of lupus is going to change in the next decade. And we are very pleased to be one of those clinical trial centers in Canada. So this is, again, same molecule, just in lupus nephritis. I like organ involvement trials better because easy to measure. Unfortunately, in lupus, you may have better in one organ, but worse in another, and then neutralize the benefit. But when you separate by specific organs, and kidney is relatively easy to measure, you have access to biopsy, you have access to urine, measure protein, and easy to do. And I think this is going to be a good study to carry on, and we already enrolled at least 5, 3, and 2 more being, we will know they get accepted in the next week. So if you have friends, family members, or who have uncontrolled lupus despite of the therapy, we add this on therapy, or you have new diagnosis of lupus nephritis, we give what we're supposed to get, and on top of that, we will give the medication. This monoclonal antibody is not a drug, it's a specific antibody blocking the crazy cells in the immune system or placebo. We will not know, it's not IV, it's injectable in the belly or in the arm or in the leg. It's relatively easy to do. People who have rheumatoid arthritis, that has been for almost 2 decades now, and it's a standard of care really nowadays in RA. That's why we don't see the deformities. But I think we will start seeing more survival, better quality of life, and ideally no more prednisone unless it's a flare. So I'm not gonna go to the inclusion criteria. You just discussed with your rheumatologist, you have to have specific markers of active disease despite being on medications, have to be adult, and you have to have specific markers of disease activity measured by BILAG or SLEDAI, which we will take care of that. And have active disease like TB, hepatitis, HIV, being pregnant, not because I think that the molecule will be safe in pregnancy, but nobody wants to do new trials in pregnancy because nobody will do actually. Anyway, this is for the lupus nephritis. You have to have active nephritis with 1 gram of protein in 24 hours, despite of being on treatment. If you are, despite of that, with active disease, you will qualify and we'll give you the medication. And this is probably what everybody has been waiting for. We are, people think that CAR T cell therapy is like giving candies, but they're not. It's a very complex treatment. And we are going to open a trial in the fall. We are being one of the 2 centers actually doing clinical trials in lupus. One is pediatrics and the other is us. And I think we'll be ready to run it in the fall. We will be only doing 2 patients. The cost of this therapy is around quite $1 million. So this is going to be free, of course, because it's done by a drug company. And basically, I think Jen already explained, is retraining T cells, removing all the other cells. That's why the chemotherapy has to happen. And then those T cells that retrain, they actually don't react with the B cells to become autoreactive and crazy. So this is a very highly technical, but I actually think this has the potential for the first time to be curative. I have in one of those meetings on the Lucy network, which is the clinical training network, I had a patient who spoke one of that meeting, and the patient, the first thing she noticed was, I felt normal for the first time. This brain fog that happens in lupus patients, she was the first, that was the first thing she noticed. I felt like when I didn't have lupus. So even if lupus comes back 10 years later, because this requires you stop all the medication. Imagine being 10 years with no medication, even if you have to retreat 10 years later, who knows what happened. The biggest concern here will be, will they develop cancer, which is a biggest concern. And time will tell, but I think for the first time, we are at the opportunity to become curative for lupus. And this is something that we cannot aspire to get it in other autoimmune diseases, but maybe will be. In BC is in a very good position, and I think at some point BC lupus will have a major role. This is a standard of care now. In BC, we develop our own CAR T cell therapy in the island, and this only used in cancer because the cancer agency pays for the salary of the treatment, the physicians and the unit at the bone marrow transplant unit at BGH and children's. But at some point, either the government will have to pay or the BC Lupus Society have to go on a fundraising campaign to make available. It will not be for everybody, but there will be probably, will become at some point a standard of care, but the costs are becoming lower and lower over time. So I think this is a very exciting time. It was very hard to convince the hematology team to do this. They always, even clinicians who do not know about lupus, they get scared. They don't want to have to deal with anything that becomes crazy and autoimmune origin. And they didn't want to do it. I have to beg them for almost a year and a half. I almost said, we will pay for it. I reached to Ivana to see maybe we need to fundraise to get at least one patient. I knew and I know that once they become familiar with the disease, they will be more open to do it. The big difference, I think, is safer in autoimmune diseases and lupus, and Jen briefly touched about. In cancer, they destroy tumors. And that's when the destruction of the tumor creates a lot of craziness with pro-inflammatory cytokines, proteins. But in lupus, there is no tumor to be destroyed. So the side effects that you will see in cancer patients will not happen in lupus. If they happen, it's very mild. They already, I think, last year at the American College of Rheumatology meeting, they presented, I think there's probably in different diseases that been tested in dermatomyositis and vasculitis and scleroderma. I don't know, they're like 200 patients, and the very minimal side effects really is very safe, at least with the data that we have. And we will probably, given that we develop our own CAR T-cell therapy here, my hope is that by the time I retire, it will become part of the standard of care in BC. And once we do this trial with 2 patients, there are tons of companies doing it. Probably the hematology team will allow us to go back and do another 2 patients and then another 3 patients. And this will evolve over the next decade, and it's going to be amazing to have it. We want to have the experience. My hope is that once we see that this is phenomenal, we will find a donor and we'll create a research unit for infusion cell therapy, which could be applied to other autoimmune diseases. It can be used in multiple sclerosis and inflammatory bowel disease. And at some point, it will become just an infusion therapy that is not for cancer, just like they are for cancer, where we all come together. And maybe we could recruit a scientist who would dedicate their life to that. It was probably, I'm going to pitch that. For those who did not, John Asdell, who was the one who recruited me and trained me, he actually was a big lupologist and is well known for that. And maybe when we recruit that person and we get that funding money to pay for the next scientist, then maybe that was what he's going to do. So the requirement for this criteria is, it's important that you guys know, we're actually going to do, we could recruit teenagers, which I think is where the big market or opportunity is going to be, because they have earlier, more aggressive disease, and they have more time to gain. It doesn't mean that those who are not teenagers, like you, could be eligible if you really require it. And the inclusion criteria is actually very simple. It's not that complicated, similar to what we're doing right now. Although we probably want to use in the patient who has a very severe disease, high dose prednisone, and still refractory, but it's easy to recruit, I think, for the inclusion criteria. And I'm looking forward to start this therapy. So now I'm going to give you a very quick overview of the things that we're doing with your money. Remember, with COVID started, Trump made hydroxychloroquine very famous because it was initially given for COVID at high dose, and more than the doses that we use currently. But then they will start showing some arrhythmias in the heart, and then they rapidly say, all people who start hydroxychloroquine should get an electrocardiogram and assessed by cardiology. And we say, maybe not. We've been using it for more than 50 years, and we don't see that. So we use the data that we have access to, and we compare if people have versus those who did not take it and still have lupus. And arrhythmias still happen without or with hydroxychloroquine, no difference. So it's very safe. We don't need to do electrocardiograms, and that actually stopped there. We don't use more resources when we don't need to do. And there was an opportunity study. Another one, this is adherence is one of the biggest problems in chronic diseases. And this is while we get the CAR T-cell therapy and the B-cell therapies, you need to remember, we already know one drug that works, that's cheap, easy, and also has additional benefits. Hydroxychloroquine not just treats lupus, but prevents complications. As you know, autoimmune diseases or chronic inflammation leads to increased risk of heart disease and stroke. But if you stay on hydroxychloroquine and you take it as prescribed at least 90% of the time, when you compare those who take it like that or those who do not take, those who take it as prescribed have less cardiovascular events. So it's not just to treat the disease, but also to prevent complications. This is not just like this research has its all, it's actually recently, but 2021, but has been demonstrated before. But in BC, we show that people who stay on the medication, despite of the disease you have, despite of those of prednisone you have, despite of the type of lupus you have, you survive longer or die less premature than people who not taking the medication. So also, stay on hydroxychloroquine prevents diabetes, which happens quite often in lupus patients, mainly induced by corticosteroids and also as a risk factor, probably inherited from before. So prevents heart disease, prevents diabetes, and increased survival. But you just have to take it as prescribed. Otherwise, you lose the effect. When you actually don't take it as prescribed, you lose the benefit. This is other type of publications we've done on mental health, access for lupus patients and related diseases. And this is from last year. And I would like to acknowledge the research comes with a team. You cannot do this without a team. And this is students, collaborators, and the funders. But this would not have happened if I would not have been recruited through the sponsorship you guys have given to me for 15 years. On behalf of my kids, I had food for 15 years, so thank you, and we'll be carrying on, and there's new people coming behind us, and you'll hear some of them today. Thank you. Questions?